Welcome to Emergency Insights. I'm your host, Kim Barker. Today, we're discussing a practice that's been a staple in nursing and emergency medicine for decades: the routine replacement of peripheral IV catheters. For years, we've operated under the assumption that rotating IVs every 72 to 96 hours is a non-negotiable step in infection prevention. But is it? The evidence is challenging that long-held belief. Recent reviews and clinical studies suggest that this routine practice might be more of a tradition than a necessity. The data shows that replacing a peripheral IV only when clinically indicated, that is, when there are signs of phlebitis, occlusion, or infiltration, does not increase the risk of catheter-related bloodstream infections or other complications compared to the standard 72 to 96-hour rotation schedule. In fact, sticking to a routine replacement schedule can increase patient discomfort and generate unnecessary healthcare costs without any added benefit in terms of safety. This shift in thinking is quite significant. The risk of complications doesn't appear to rise with a longer dwell time, provided the catheter is regularly monitored. For adult patients, the CDC's current guidelines recommend a scheduled replacement at 72 to 96-hour intervals. This recommendation is based on evidence that while the incidence of thrombophlebitis and bacterial colonization might increase after 72 hours, the rates of phlebitis don't differ substantially between 72 and 96 hours. The aim here is to strike a balance, minimize infection risk while also reducing patient discomfort. Now, let's talk about our pediatric patients. The guidelines for this population are different. The CDC recommends replacing peripheral catheters in children only when clinically indicated. The reasoning is that pediatric patients have a lower rate of complications overall, so routine replacement isn't necessary and can cause undue stress and discomfort. While scheduled replacement may have some benefit in reducing phlebitis, studies comparing a 72-hour plan removal with removal as needed have shown very similar rates of phlebitis and catheter failure. The big takeaway is that we need to continuously question our practices and ensure they're backed by solid evidence. The days of "we've always done it this way" are over. Our focus should be on patient-centered care that minimizes discomfort and cost while maintaining the highest standards of safety. And that's your emergency insight for today.